Thanks, Glenda. I appreciate the introduction. Hi, everybody. Afternoon sessions are always a little bit tiresome, so just feel free to raise your hand, make a comment. We'll just have a very interactive session. So how many of you guys are hospital-based? Anybody hospital-based? Excellent, excellent, excellent. Community-based? Health department-based? All right. So I tried to veer as much as possible to the community outreach projects that I know are going on around the state. But a lot of my talk does relate to the Baby Friendly Hospital Initiative. And I would love it if somebody could go back and take it to your home hospitals and say, you know what, this is a really cool initiative that you should look into. So first of all, breastfeeding is a public health issue. And it's just like any other public health issue that we deal with. It's like immunization. It's like obesity. It's like smoking. It is a public health issue. And so while we get so caught up in, let's not make moms feel guilty, let's be careful about our message, we need to boil down to, it's a public health issue, okay? And so when we couch it in that way, then a lot of our message can be delivered in a more clear manner. This is from 1938, so this is when part of the New Deal stimulus package back then. And it says, nurse your baby, your protection against trouble. So, love that, right? It's very simple, effective. Here's the photograph. So the benefits of breastfeeding for infants, and I'm going to quickly go through these so that you guys can, just as a review, hopefully. I love this particular Agency for Healthcare Research and Quality report back in 2007. What this quality report did was it looked at a lot of the breastfeeding research and said, what's real, what's maybe, and what can we not prove? And because it's so difficult to sort of sort out what's been well done and what really needs to have good scientific basis behind it. So when they looked at ear infections, otitis, ear infections, 23% less for babies who were ever breastfed. And for babies who are exclusively breastfed, about a 50% reduction. So that's a huge, huge benefit there. For atopic dermatitis or eczema, you're going to get a 42% reduction for infants who have a family history when they are exclusively breastfed. For lower respiratory tract infections, you're going to get a reduction in hospitalizations. For obesity, it's a huge topic right now, and I think the numbers on some of the more recent studies are even better than this, because when you breastfeed a baby, they monitor their satiety cues better, so they tend to have less obesity, up to 24% reduction in some of the studies from 2007. For diarrheal illnesses, 64% reduction. There's evidence for reduction in the relative risk for SIDS, asthma, type 1 diabetes, and non-accidental trauma. And those reductions are huge if you think about it, the things that you can benefit from that. So what about the IQ points? So the IQ points are really a little more difficult. IQ testing is fraught with sort of difficulty measuring. And then when you think about maternal IQ and trying to control for that, we see very good impact in our preterm babies. Term babies, the differences in brain development are there, but I don't know about the IQ points. So it's probably best to talk about it in terms of brain development. Benefits of breastfeeding for mothers. So there's a lot of benefits. And when I talk about these top benefits, decreases type 2 diabetes, ovarian cancer, breast cancer, cardiovascular disease. Well, my patient population, if I'm talking to an 18-year-old, is that going to be impactful for her? No, probably not. So what I tend to talk about are the more immediate concerns, that it may help you get to your pre-pregnancy weight a little sooner. It may decrease your postpartum bleeding. It may reduce your risk for postpartum depression. So those are the things that I'm going to talk about to that younger mother. I'm going to go over the other benefits, but I want her to think about the things that are more immediate for her. Other benefits, economic. So this was a study done in Pediatrics in 2010. A lot of variable thoughts about how this study was actually put together, but the basic quote from it is that there would be a U.S. cost savings of $13 billion per year if you could achieve a 90% breastfeeding rate across the United States. If you extrapolate that data to Tennessee, potentially we would have a $200 million a year cost savings. Environmentally, potentially decreased bottle usage, less washing and fewer bottles to dispose of. We all want to be green, right? So less formula packaging waste can be another benefit. So the risk of formula. So we are talking about benefit, 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 and we make such a good point of mentioning the benefits that sometimes it's seen as an added or as a bonus or as the extra credit on the test, you know? And we need to turn that around and have it be the normal. And then if that can't be your normal, then we need to talk about formula. But the other way to think about it is, what is our risk of formula? So the risk of formula is that it alters the gut flora. It increases the risk for necrotizing enterocolitis and for diarrheal illnesses. And so for our preterm babies, this can be a huge Problem. May sensitize the infant to foreign proteins, thereby increasing their allergy risk, and this is more true for families who already have a little bit of a risk. May impact mom's supply. So if you have a mom who says, I want to do both, and that's something we hear all the time, you have to respect that is her choice, but you want to make sure she understands fully what she is asking for. Because she may fully believe that she's going to be able to breastfeed that baby and formula feed that baby at the same time and have normal milk supply. And for most mothers, that is not going to be true. And once you start introducing formula, it can definitely impact mom's milk supply. Impact a baby's ability to latch. So I have children who went back and forth between pacifiers, bottles, whatever. They did fine breastfeeding. But we cannot predict which babies are going to be able to go back and forth without problem. Okay? So if you do not need to supplement with a bottle, then don't do it, because you cannot tell how that's going to work for these babies. The other thing that I always mention is the risk of formula contamination or inaccurate nutrient ratios. This is from the FDA formula recall regulations from July of 2011, and they report that 2 recalls per year for the past 3 years. And so you've got human error. One of the recalls was for beetle parts. You've got things that happen with formula that you need to also consider when you're weighing your decision about whether to breastfeed or not. So the work of breastfeeding. I think we all have to acknowledge that the work of breastfeeding is harder, especially when you're first getting started and first learning. It does not come naturally or easily to a lot of mothers or to a lot of babies. And so we need to acknowledge that it is more time consuming initially, because it can be really discouraging for a mom if she goes in and thinks that something's wrong, because it isn't just perfectly natural for her. Studies show that maternal sleep quality is comparable between breast and formula feeding. So when we talk about a little bit later on about how important it is to room in, we're going to talk about this some more. Breast milk is available without any bottles or warming, therefore in the end is going to be very convenient. In terms of feeding during an emergency, think about it. If you've got non-clean water supply, you don't have any way to heat up that water, you've got breast milk right there, perfect temperature, you're good to go. Requires no trips to the grocery store. So that can be huge. The other thing that I would always point out is that for a lot of our families who do WIC is a supplemental feeding system, right? It's not meant to replace every bit of formula that that baby needs. And so if you have a family who's already cash-strapped and they need to provide good nutrition for their entire family, what's going to be the better bargain for them? The better bargain for them is to choose the breastfeeding package for their family and not have to supplement and go to those trips to the grocery store to buy that extra formula. So the American Academy of Pediatrics, the policy says exclusive breastfeeding for 6 months. Who knows what comes next? Does anybody know? And continue breastfeeding for 12 months and thereafter as long as mutually desired. So there is no upper limit to breastfeeding. There's no evidence to show that there's any harm for extended nursing. And that's something that we all need to readily acknowledge and support moms in their decision. This same statement is supported by the professional organizations for obstetrics and for family practice. I feel like I'm looking backwards a lot, sorry, with my tether. All right, so the laws regarding breastfeeding, and these are things that, especially in the public health arena, it is our job to get out so that moms know what the law is, because they don't. They often have no idea. So the federal law says employers must provide a reasonable break time in a clean place for mom to be able to express her milk, not a bathroom. So that is something that a mom has a right to have. But if you think about where our families sometimes work, they may not have the empowerment needed to go to that boss and say, I need a clean place to pump my milk. That's where community activists and community support and medical professionals come in to support that mom. In Tennessee, women may breastfeed in private or public locations without fear of indecency laws. And this is also a huge law that people need to be aware of. So,
not many people know that. I ran into somebody who actually thought it was the opposite, that there was a law.
That there was a law against it. Mm-hmm. They recently took off the 12-month criteria, so they can breastfeed as long as they want.
Yeah.
So,
and then there's also, I think it's Title IX, but I'm bad with numbers on that provides for a student in a high school a place to pump and store their baby.
Oh, that's great. That's great. That's wonderful. I'll have to put that on the slide, Glenda. You need to remind me. So the Healthy People 2020 goals. So 81.9% to initiate breastfeeding, 60.6% to continue at 6 months, and 34% continue at 1 year. And so Tennessee, how do you think we're doing? So 64.3% initiate breastfeeding, 30 at 6 months, and 13% at 1 year. And for that initial initiate breastfeeding, these may be moms who latch that baby on once. These are not sustained feeders. This is not exclusive. This is any breastfeeding. And this is from the CDC report card from 2012 and readily accessible on the CDC site. So for our exclusive rates, about 33% exclusive for 3 months, 13.9% for 6 months. But this one is shocking to me, the percentage who received formula prior to 2 days of age. So I will tell you, for Vanderbilt, our percentage is much higher than that. Much higher than that. And we'll talk about the reasons for that in a little bit. So when I look at the states, this gives me hope. I mean, because look at it. You heard I was from Alabama. So Alabama's actually doing a little better than Tennessee on this. And that's shocking to me. But if you look at the states that are dark blue, we have hope. It can be done. We can get these breastfeeding rates up. What it takes is a change in our culture. What it takes is lots of community involvement. It takes that mom seeing the images of breastfeeding and hearing that message over and over and over again. So exclusively breastfed at 3 months would be they have nothing given to them other than breast milk. That's a great question. Most families are introducing complementary foods at this point in time, and so this is not exclusive breastfeeding. This is any breastfeeding. That's a really good question, really good point. So the MPINK survey, for those of you who have any sort of attachment to a local hospital, I'd like for you to go and ask them, I'd like to see a copy of your MPINK survey. And they're going to look at you and think, what in the world? What does she know? What are we talking about? This is the maternity practice survey from the CDC. They have an 80% response rate from the birth hospitals around the United States. And it compares your hospital's maternity practices to all the other hospitals of comparable size and to the rest of the hospitals in the United States. So it breaks it down quite nicely. So you can see how you compare across your state, how you can compare to hospitals that are your size, and tells you sort of how you're doing. So Tennessee's strengths. We do really well at documenting mom's intent. So we did great at saying mom's going to breastfeed or mom's going to formula feed and checking that box. We do a good job at that. That's good, right? We do a good job at making sure that our prenatal classes include breastfeeding information. So what's your next question for me about that statement? Right, so how many of our moms access our prenatal classes? Yeah, a fairly low percentage. Most classes are fee-for-service, or they're difficult to access, or there's transportation issues. There's lots of different reasons why we aren't getting our message out. And so, yes, we do a good job of including it, but if the mothers aren't accessing it, then what are we doing? One of the things that we notice for Vanderbilt is the moms who access our classes are the mothers who also probably are receiving lots of other education in other places. So our weaknesses, lack of a model breastfeeding policy. And a model breastfeeding policy we're going to talk about in a little bit. That policy includes 10 steps for successful breastfeeding. And it has very set things that we should do as hospitals to support best breastfeeding practices. Inappropriate use of supplement, which we'll talk about a little bit later, lack of discharge planning support, and poor rooming in rates. It is sort of our cultural expectation that the baby's going to go to the nursery at night. And it's very difficult for our nursing staff to get that baby back out for feeds in a timely manner. And that's something that is going to take a long time probably to correct. So when you think about all these obstacles, you start thinking, okay, what in the world? How do I even start? Where do I even begin? And I think you just really need to break it down and figure out what he was talking about earlier. Where do you fit into that pattern? What is your niche? What are you doing to make this situation better? So think about first in terms of promotion. So public awareness campaigns, those can be huge. Access to prenatal and breastfeeding classes, how do I make those more readily available? How do I publicize those so my moms can access them more? What do I do to make these work? Support. So you can promote all day long, but if you don't support, then basically what you've done is make mom feel like a failure when she can't meet her breastfeeding goals. So you can promote and she's all enthusiastic, ready to go, and then the baby doesn't latch well, and then her milk doesn't come in, and then what does she do? So you really have to have these things as a team. And finally, protection. So then it's time for her to go back to work, and she needs a place to pump, and she needs to have somebody to support her, right? So these things all need to be done in conjunction with each other. But the beauty of it is you don't have to do every one of these things. You can work with other people, find ways to make this happen. So, I am very much in favor of our baby-friendly hospital initiative, But I know that I can't educate those moms when they hit my door at Vanderbilt. It's not going to work. And they're only with me for about 2.1 days is our length of stay. So I can't do all their breastfeeding education right then and there. So I really have to have community partners and ways to get that campaign out. So I'm going to talk a little bit about community campaigns, what's been successful, some of the things that are going on around the state. Some of you, I know, have been involved in these campaigns. So this is the NASH Vitality campaign. This was everybody aware of it? Has anybody not heard of it? Okay, so it's a really great campaign funded by the stimulus package. It's a breastfeeding promotion campaign from Metro Health Department. And basically the beauty of this campaign is it was funded for a certain period of time, but then the things that were developed from this campaign live on. And they are able to be reproduced by hospital organizations, by breastfeeding coalitions, and various things. So the Give Me 5 Hospital campaign, they basically went into the 5 birth hospitals in Davidson County and said, if you will change your breastfeeding policy and meet at least 5 of the baby-friendly steps, we will give you an award that says you've met these 5 steps. Guess what? 4 of the hospitals did it. And 4 of us have gotten this award because it is important to be recognized for that work and to follow evidence-based practice. And our health department did a great job with that. The next thing they produced is the Mom's Guide and Dad's Guide. These are guides that basically outline the breastfeeding rights of a person. It's in English, Arabic, and Spanish. And it's on their website, and it's reproducible, and you can print them all day long. And it's great. It's a great resource for patients to have. And if any of you have tried to find Arabic materials, they can be very difficult. And so it's great to have somebody to sponsor that and get that out there for the hospitals to be able to use. The final thing that's an ongoing campaign that I'm going to talk to all of you about because I hope you'll get involved is the Breastfeeding Welcome to Your Business campaign. This campaign was actually initially passed off to the Nashville Breastfeeding Coalition, which really started out as an offshoot of the NASH Vitality campaign. So basically what's happened is this is spread now and it's become a really grassroots community organization to get the breastfeeding message out. And then what happened is what had been our Tennessee Breastfeeding Action Committee became our Breastfeeding Coalition. And so now we have a statewide coalition that goes down to each one of the individual coalitions. Anybody know where your coalition is nearest you? Yeah? All right, good. So we've got great coalitions in Shelby County, a very active one in Memphis. It's a wonderful coalition. We have one in Johnson City, one in Knoxville, one in Jackson, and then Nashville. So am I forgetting anybody? So I think that's all. So this is the Tennessee Breastfeeding Coalition. The state coalition has taken this out now. All the local coalitions are welcome to use this material. And what you do is you go to the business and say, I'd like to tell you about the breastfeeding laws of our state. I'd like to tell you about what your employees are entitled to do. I'd like for you to take a pledge that you're going to support these breastfeeding laws. And when you do, I will give you this sticker and you can put it on your door, saying that you've agreed that breastfeeding is welcomed at your establishment. So we've had really good success with a lot of our businesses in East Nashville. You'll see the stickers, Whole Foods, some of the bars, Bosco's, which is a bar/restaurant. I shouldn't say a bar, but that sounds bad. And then we've taken that even one step further and put it in Commodore colors, so for Vanderbilt. And so, go Doors. They're going into individual sections of Vanderbilt to make sure that our folks are aware that you can't tell a mom to cover up, that she does have the right to breastfeed wherever she wants. And we've gone into even providing some scripting, saying, so-and-so comes up and says, I'm uncomfortable because there's a mom breastfeeding in the waiting room. What do you say to her? Well, you don't say anything to that mom who's breastfeeding in the waiting room because it's her right. What you say to the person who has come up to complain, you say, I understand, you validate their feelings, you provide them with the information about the law, and then you offer to seat them somewhere else. Because it's not that mom's issue, it's that person who's complaining. So this is another great thing to think about. Who in your community, you've got community activists all over the state who want to be involved and want to do the right thing to help with breastfeeding promotion. Julie Hamilton is that person for Nashville area. And she has a nonprofit called Julie's Village and is partnered and is actually the director for the Nashville Breastfeeding Coalition. So she has formed these great partnerships to develop this Best Baby Shower. And what this is, it's a baby shower, baby fair that's providing breastfeeding-friendly education. So moms can come in and take a free breastfeeding class. They get to go to vendors who are breastfeeding friendly, so there's no formula company sponsoring this fair. And then they come away hopefully being more empowered with what they can do when they hit the hospital. And her website's up there and it will be on your slides. So this is East Tennessee, Johnson City. Dr. Karen Chepsina leads their breastfeeding efforts. And they have a mother-friendly campaign. It is online at their website, and the businesses in the East Tennessee area can go and sign up for this. Shelby County, Dr. Julie Ware in that area, great coalition there. This is one of my favorite campaigns they did several years back. They've had many campaigns since then. This is still my favorite. I love this campaign. I think it's beautiful. And it says babies born to be breastfed. The other thing they've done is they've done a really good job partnering with their faith community to have milk missionaries to go out and provide peer support for moms who are nursing. All right, we've got to talk about WIC. So the Grow and Glow program, this is a huge, huge, huge help. And I'll show you a little bit later as we start going through the Vanderbilt data. We are friends with our WIC folks. They are huge help for us in the breastfeeding fight. The Department of Health and Human Services, this is a great place to go and get a free book to be able to give out to moms. And you can print it. They did have a grant, and you could call and get copies delivered to your hospital, but the grant money right now is on hold. So you can still print it. And it gives all the nuts and bolts of breastfeeding right there in one book. Joint Commission. So Joint Commission always makes me get a little bit, like, oh. So this is their Speak Up campaign. Joint Commission several years ago decided they were going to add exclusive breastfeeding as one of the measures, the perinatal core measures for hospitals. So it is now one of the things that hospitals are starting to collect because it is going to be something that Joint Commission will eventually measure. So that leads us to what is Baby Friendly Hospital Initiative. So this specifically recognizes birth facilities that implement the 10 steps for successful breastfeeding. And it is a WHO UNICEF initiative from about 1991 where they looked at what does our evidence say would work best to support breastfeeding in a hospital environment for term babies. This is not for NICU, it's not for preterms, it's for term babies in a term nursery. What's going to work best to give that mom the best support to meet her breastfeeding goals? And to basically to reach baby-friendly designation, there's about 4 steps you have to go through. It takes roughly 3 years to fully be designated because it takes that long to get all the processes in place. And it is used as a process indicator on the CDC report card. So it is how you're judged. It is one of the things that they use to look at your hospital. So who recommends it? CDC, Surgeon General, Institute of Medicine. The Institute of Medicine actually lists it under their obesity prevention, which I find very interesting. And then the AAP. There are about 143 hospitals surveyed that have passed. That changes quite rapidly, so those numbers are as of May. There are 2 birthing centers in Tennessee over in the eastern portion of the state. But there are 19,000 hospitals internationally, so you know that this is something that we can do to support it.
What year is Vanderbilt in?
Vanderbilt is in the second. We're about to submit our paperwork for the 3rd stage. So, and we're sort of... We've launched some staff training and things that are actually part of 3rd stage just because of where we are in our process. So breastfeeding cessation in relation to baby-friendly steps. So if you look at this slide, I don't really have a pointer, but from 0 to 6, so the moms who had 6 baby-friendly steps implemented in their hospital setting had a 3.2% rate of stopping breastfeeding before 6 weeks. Okay? Now think about that the opposite way. If they had no baby-friendly practices, they had about a 30% chance, a rate of stopping. So we do know that it makes a difference. What baby-friendly is not, it's not about forcing a decision on a mom. So I think you have to be really clear on that as we go through these slides because I tend to get really enthusiastic. But that's not what it's about. It is about making sure that your hospital practice supports everything that the mom chooses to do and provides her with the education. So the first thing you have to do is maintain a written breastfeeding policy that's routinely communicated. So if you have not been in a hospital setting, there's lots of policies, and we don't always know what every one of those policies are, especially if you're not directly involved in that particular area. So you want to make sure that you get that policy out and that the nurses really understand what it says and what it means. So the policy has to be posted. It should include all 10 steps. It must include some sort of statement about the International Code of Marketing of Breast Milk Substitutes. Anybody know what that is? Any clue? Okay. Basically what that says is formula should not be marketed directly to the public. That formula should be used for nutritional value for an infant who needs it or for a mom who has a contraindication of breastfeeding, but that a lot of the marketing that's done should not be done. So there are several places to find examples of the breastfeeding policy. One of the ones that I really like is this recent one in the Journal of Human Lactation, and it goes through the policies that were implemented in the New Jersey hospitals, and those have gone through baby-friendly designation already. So it's a real down and dirty, you can look at their policy and you're done. You don't even have to think about it really. So here's what I was talking about, the WIC packages. We changed our policy in January of 2012. The green line is our fully breastfed WIC packages requested. So this is our patient population who we can make the most impact for because they are often our families who aren't breastfeeding when they come in. So if we can change one mind or help one mama make that decision to at least try, then I think we've done a really good job, and you can see our rates are going up quite nicely since then. This is in conjunction with the Grow and Glow. So they're hearing it at the WIC offices too. So it's not something that we've done in a bubble. The second thing is to train all healthcare staff in the skills necessary to implement this policy. Now, this may sound like a no-brainer, right? All nurses are trained in breastfeeding, right? Right? You work in a hospital setting, right? So, but what it requires is that the nursing staff has to have 15 hours of breastfeeding training and at least 5 hours of direct hands-on lactation training, so that you won't have a postpartum nurse say to you, I don't know how to latch that baby on, that's not my job, let me go get your nursery nurse. So what we hope to happen is that any nurse who comes into contact with you on that postpartum unit will be able to say, yeah, I can help you, here we go. Providers, so that would be the midwives and the physicians and the residents, must have 3 hours. And you thought the nurses for 15 hours was hard? Getting the physicians and the providers to do 3 hours is almost harder, to be honest. Training can be accomplished in a variety of ways. So you can give lectures, we've got games show kind of things where they buzz in for answers. We've got computer modules. We've got lots of different ways that we're rolling out this education. Because quite frankly, to have somebody sit in a classroom for 15 hours, first of all, we can't afford it. And second of all, their eyes would glaze over and about half of what we said would be heard, right? So we really need to make it more fun and more interactive. And the new hires have to be trained within 6 months. We have a nursing staff, roughly 200, 250 that will be going through this training. And we started last week, so with our OB nurses. And it's an undertaking, and it's lots of fun. We get to learn a lot. Patient education. So this is a huge one. This is not something that you can ever do in a bubble. You have to look outside of your organization to get help with this. So inform all pregnant women about the benefits and management of breastfeeding. I love the way it says inform. So I'm going to sit here in front of you and I'm going to inform you. That's not the way that you should have conversations about breastfeeding. You should say to a mom, tell me what you're thinking. How are you going to feed your baby? What are your thoughts? How long are you planning to feed your baby with a breast? When are you going back to work? Have you thought about what you're going to do when you go back to work? And have sort of an ongoing dialogue about what's best for that family. So interventions to promote. I use promotion and education sort of interchangeably. What do you think works well? Well, we know that it has to be prenatal and postnatal. So you can talk about it all you want prenatally, but when that baby comes out and that mom's just had a C-section and she's not feeling so great, it's hard. And you're going to need to be there to provide that postpartum support and that re-education about, yeah, that's normal. Remember we said that they may not eat really well in that first 24 hours and they may be really sleepy. And so you're going to need to be there to be supportive of her decisions then. Written material alone is not effective. We give out these really lovely books. They're called the New Life books. They're about that thick. And we give them out in the prenatal clinic. And when we surveyed our moms to ask if they got prenatal breastfeeding education, we had about 20% who said yes. Now, mind you, 100% of them get that book, but 20% of them said yes. So we really need to think of other ways to educate our moms. We know that visual imagery, that video, that person-to-person contact, anything that has sort of a sound and a sight to it is going to work better than written material. Most important influence, you know the most important, who's the most important influence? Significant other. Grandma, boyfriend, partner, it's going to be the most important person for that mom. So prenatal interventions, you want to provide the education and correct the false beliefs. So you may be working in a health department setting and that mom may be signing up for her WIC package. That is a prime opportunity to say, so tell me what you think about breastfeeding. And when she says to you, it's going to make my breast sag, that's a great time for you to say, but you know what? There's lots of things that make your breast sag, and it's not just breastfeeding. And you can go and correct those false beliefs because there's a lot of them out there. look for contraindications. There are contraindications. Anecdotally, you're going to hear all these numbers thrown out about who can't breastfeed. There's no great research on that. There's no real proven number. We know that HIV, active herpes lesions on the breast, active tuberculosis, although you can pump that milk, infants with galactosemia, some moms who have had major breast surgeries, breast reductions, will have trouble. But true contraindications are actually pretty rare. And the more common story we hear is, my milk didn't come in. So, right? So why did your milk not come in? So that's always something to kind of go back and think about. Was it because we didn't give you great information, or we didn't support you really well, or we didn't get enough feeds in while you were here in the hospital? You know, what caused that to happen? Because we know that truly it's fairly rare that you can't breastfeed. Provide resources for structured classes or support. I found out really recently that our WIC families had access to breastfeeding classes. Those have been going on for a really long time. And so then I thought, well, probably everybody knew that but me, right? And so then I called my friend over at the OB clinic. I said, did you know there's WIC classes for breastfeeders? And she's like, oh, really? And so then, you know, it's one of those times where it's so obvious that we just aren't doing a great job communicating. And I just didn't know. So complete a breast assessment and provide prenatal lactation referral if abnormality is suspected. This is more for our OB colleagues because there are times where moms come into the hospital and they say, I had flat nipples, or I had a surgery, or da-da-da, and nobody's ever really even looked. If you look and you suspect something, it's a great time to send that mom on to lactation and have them looked at. All right, so the next one is to help moms initiate breastfeeding within 1 hour. Within that first hour, and they don't necessarily, this wording is a little bit funny now, they don't necessarily have to breastfeed within that first hour. You want to be skin to skin within that first hour. And we know that what generally happens at that point in time is that skin to skin, yes?
I'm sorry.
No, you're okay.
But when you say within the first hour, is that for babies that are not premature or have to go to the NICU?
Term babies, yeah. We don't ever want, if that baby's having trouble breathing, don't put them skin to skin. That is not, it's safety first for sure. This is meant for term, stable babies and stable mothers. So if you have a mom with postpartum hemorrhage, she doesn't need to be worrying about skin to skin at that particular point in time. We can do that later when she's stable. But for stable term babies, skin to skin, immediately after birth, within the first 5 minutes. So what should happen, what we like to happen, we do delayed cord clamping. So we delay our cord clamping for 2 minutes on those babies. They're usually on mom's tummy. And then we want them to go to mom's chest. And we want them to stay there for the first hour uninterrupted. That is hard because then what happens? Everybody wants their hands on that new baby. And so what we generally try to tell the mom is you did all the work. You should get at least the first hour to have this uninterrupted time with your baby. We know that term infants regulate their temperature better. Their glucose stabilization is a little bit better, and they tend to breastfeed better if they have that time uninterrupted with their mama. The other thing that you want to think about is skin to skin after C-section. That is such a conversation that I know that I had never heard of 4 or 5 years ago. But we know that it can be safely done, and it's being safely done at hospitals around the country. So why are we not doing it? And so we're looking at ways to do it at Vanderbilt. We've actually started figuring out some protocols and things. Again, this does not apply to anybody who's not stable. So our skin-to-skin rates, just by providing nursing education and going back and providing some education for the mothers, gone up quite nicely. We now have about 70% of our babies going skin-to-skin, our eligible babies. So that's our non-NICU healthy term babies going skin-to-skin. Our goal is 80%. We want at least 80%. Eventually, our goal will change to 100% because we're always going to just increase it as soon as we hit it. So steps 5 and 6. Show mothers how to breastfeed and how to maintain lactation even if they're separated from their infant. So this goes into that whole, my baby's not doing well or I'm not doing well, my baby needs to go to the NICU. Well then, how do you have that conversation? So now you've got a sick baby, go into the NICU. Dr. Markham, you've probably had a lot of these conversations. And one thing I usually tell the mom, if I have the opportunity to talk to her, is this is something you can do for your baby. It's a very empowering thing to know that they can participate a little bit in that health care for their baby. But it can be really hard. They're really emotional. We want to get this started within 6 hours, though. That's our goal. We want to get the pump in the room and them pumping within 6 hours after that delivery. And so it can be in a really emotional time for them. And it very much helps if they have the expectation of that before they come into the hospital, right? So give infants no food or drink other than breast milk unless medically indicated. This may seem like a real no-brainer to most of you guys, right? Of course, if they're going to be breastfeeding, why would you give them sugar water or why would you give them sterile water? But we know from surveys on the MPINK survey from the CDC that hospitals are still occasionally using things other than breast milk. The most common reason for supplementation at Vanderbilt is parent request. And no matter how much you do to try to reassure those families, it can be really difficult. Moms need to have that appropriate information. So you want to go back over your buzzwords. Milk comes in on days 3 to 5. The baby's tummy's really small, like the size of a ping pong ball. You want to go back over and let her hear those things multiple times. Hopefully you're not the only one saying them. Hopefully she's got nursing staff and other people saying them. Because you do have to be careful, because you don't want the baby to be not gaining and you not realize it. So around day 5, you should really see sort of they're going to start upticking. They shouldn't have meconium in their diaper at day 5. You should start to see that the milk is really, you're hearing good sucks and swallows, the baby's weight stabilizing. And if you need to weigh them daily, my advice would be weigh them daily. See what they're doing as a trend rather than making a decision. But if you've got a baby coming in and they're 13% down, that's a different conversation. If you've got a baby coming in at 2 weeks who is still well under birth weight, that's a different conversation. But if you've got that baby who's just a slow gainer but has steadily gained, then you need to have a little more patience. The other thing I would suggest is having them see lactation. Lactation can do pre and post feeds and see exactly how much the baby's transferring. Mom can pump and see how much she's able to get with the pump. All kinds of things you can do before you actually start supplementing. That being said, if the baby is jaundiced or looks dry or any of those things, then that's a different conversation for sure. And I would hope the more that pediatricians are educated, they'll start to realize that, 7%, let's watch it. Let's see what they're going to do.
So you're saying like 13% is where you're...
10% is what catches my attention. 10% under birth weight always catches my attention. And then you want to do a full assessment. You want to see what the baby's doing when they nurse. And I usually watch a feed. We have the ability to do pre and post feeds in our clinic. So we will do a pre and post feed and see how much baby's getting. Most of our families are very willing to come back the next day. So we'll have them come back and see what they're doing. Because sometimes you're just catching them right at that bottom and they will hit the upper mark. So, all right. So ban the bag campaigns. This sounds really aggressive. But we know that moms, when they're sent home with formula bags, are more likely to give formula. Their breastfeeding duration is impacted by these formula bags. And there's really nothing to be gained for the hospital. We do receive free formula from a lot of these companies, but if you don't give out the bag, they don't take away the free formula. Now, eventually, Vanderbilt will pay for our formula for our term nursery, but we don't give out the bags. And we haven't given out bags since January of 2011. We had lots of conversations about what we could do to replace these bags. Is the mom going to miss them? Is it going to be a problem? Are they going to bring in these coupons where they want to exchange them for the bag? And when we explained to our nursing staff, here's why. Now, there's still a few that are not happy that we've given up the bags. But when you really go in and explain why we're not doing the bags and why the moms who need them the very most, that was one of the arguments. But I have moms who really need them. Well, that's the mom who really needs to be supported in breastfeeding because she may not have had any of the other things done for her. Then we've gotten some people to really come on board, and we have not received any patient complaints about this. There are states who are now completely bag-free. Massachusetts completely bag-free. Rhode Island completely bag-free. There are no discharge bags given out in those hospitals. So, all right, rooming in. This is a sticky situation because you got to be kind about this one. You may have a mama who is just exhausted. She's labored for 3 days. She's got nobody in the room to help her. What are you going to do? She's in tears. You got to support that mama. That comes first. You can't make the mama crazy because crazy mama equals unhappy baby. It all is together. So you got to be kind about this one. But when we looked at our Vanderbilt folks, you had 4 to 8 times these babies were being pulled out of mama's room for hearing screens, for doctor's exams, for whatever. Well, they got pulled out. Say the doctor's coming. They call. We're coming to see our baby. 30 minutes later, they walk into the nursery, right? You've done this. And then they do their exam, go talk to the parents. They never tell the nurse that they're done. So in between time, they get missed, and the baby's sitting in the nursery. Well, that nurse has 6 to 8 babies to take care of. So that baby starts mouthing, or they're reading. They're looking for time to eat, right? How is the nurse going to recognize that? Well, she's going to recognize it when the baby starts wailing. And so if you're telling a mom, feed on demand, feed on demand, feed on demand, and then the baby comes into her and they look like that, how are you going to get that baby latched on? So that is something, if anybody's ever tried to latch on a baby when they get to that point, which I have, it is not fun. So the other thing we've implemented is quiet time. So if you can't get the rest during the night, let's get some rest during the day. So we have basically shut down our lights, no janitorial staff. It's called our quiet time. So from 2 to 4 on our unit every day, we basically close it down. Let's be quiet. Our nurses love it because it gives them time to chart. It gives them time to get some things done that need to be done. It gives the parents just a brief moment where there's not 1,000 people coming in and out of their room. Now, for babies who are sick or NICU babies or new admissions, they fall out of quiet time, obviously. But for our term babies, this has been a really important and positive step in the right direction. Encourage unrestricted breastfeeding. So what this means is it's no more of the 15 minutes on each side kind of business. It is watch the baby, watch the baby, watch the baby. But you can only watch the baby if they're rooming in with you, okay? So that's where that goes back to. Give no pacifiers or artificial nipples to breastfeeding infants. That is during the hospitalization. And then at about 3 to 4 weeks, our advice on that changes. So at about 3 to 4 weeks, you want to consider introduction of a pacifier because it may decrease the baby's risk for SIDS, okay? But during those first few days in the hospital, a pacifier is often used to prolong the interval between feeds. And we don't want to do that. We want that baby to be nursing. Foster establishment of breastfeeding support groups and refer mothers to them on discharge from the clinic. This can be hard to do. It's sometimes difficult to find a low-cost lactation follow-up group. So remember La Leche League is a great resource. WIC offices, peer counselors, great resource. You've got to be able to help your moms identify what's going to work for them. Because if you tell them to go to some group that's way over on the other side of town, they're probably not going to do that. So you need to look what's close to their community. So here's where we are with our exclusive breastfeeding rates for our nursery at this point in time. We're really excited. I will tell you, we were very disappointed by the little drop we experienced in July and August. We had a high float pool census at that point in time, so we're sort of wondering if that was part of the problem. Then when we look back and drill down at our data, we realized that 13 babies got 1 bottle. That threw them out of the exclusively breastfed and threw them over into the mixed feeding. So if those 13 mamas had received, sort of that pat on the back, you're doing a great job, would they have still made that same decision? I don't know, but that's something that we're going to be working on. So here's some things that we were talking about just a minute ago for lactation support. The other thing that I'm not going to go into quite as much, but I would love for you guys to look at, is the business case for breastfeeding. For any of you who have not seen this, all you have to do is go onto the Women's Health site and they will send you a free copy of it. Or you can even download a lot of the materials from the site itself. And it's a great thing if you're doing any kind of workplace initiatives to kind of look at what's my argument going to be when I go in to talk to this employer about why the mom should be allowed to nurse. Well, what you're going to say to him is, you're going to spend some money, but you're going to save money. You're going to spend some money identifying a small space or a place for her to be able to pump, but in the long run, it's going to save you some money because she's not going to be out of work as much. And this makes a great argument for how you do that. This is another additional resources for you guys, just in case you want to do any more breastfeeding training or breastfeeding education. These are free sites. I love that word, free. And they're great sites for training your staff and just getting a little more education out there.